So imagine your body's immune system just suddenly decides to wage this localized war on, well, your most sensitive skin.
Yeah, it's an incredibly harsh reality for a lot of
It
people.
really is. And to make it worse, the absolute gold standard treatment that your doctor hands you is this cream that, over time might actually thin your skin even further.
Right, which feels
Ew.
totally counterintuitive.
Exactly. And that is the frustrating, completely silent reality of a condition called vulvar lichen sclerosus,
Hmm.
or LS for short.
Right.
So for you listening right now, whether you are personally navigating this exhausting maze of chronic health issues or, maybe you're just fascinated by the cutting edge of regenerative medicine, this deep dive is for you. We're going to explore a very specific, highly debated medical frontier.
We really are. We're dissecting the therapeutic landscape of a disease that is just biologically complex and emotional devastating.
Yeah, it takes a massive toll.
It does. And we're aiming to see if regenerative biology can succeed where traditional pharmaceuticals are sort of, well, hitting a wall.
Right, so the core mission today is to answer one central question. Can the O shot, which is this heavily marketed clinical treatment that uses platelet-rich plasma, or PRP, can it actually help treat the chronic, painful scarring of vulvar lichen sclerosus?
Because, I mean, the internet is just flooded with wellness trends, right? Especially when we talk about intimate health. Everyone claims to have a miracle cure.
Oh, totally.
Yeah.
Which is exactly why we need to look at the actual data. So to get past all the glossy marketing brochures and the, clinicked upsells, we've pulled together a massive stack of sources for this deep dive.
Yes, some really robust material today.
Yeah, we're working with official European and British dermatological guidelines, comprehensive scoping reviews from medical journals like MDPI, registered clinical trial protocols, and real-world data from specialized women's health clinics.
And our objective here is to look strictly at the biological mechanisms of platelet therapy. We want to analyze the physics of how it's prepared and scrutinize what the peer-reviewed clinical data actually proves. Cut through the hype, basically.
It's exactly. Cut through the hype. Because I was reading through the European dermatological guidelines in our stack, and they classify lichen sclerosus as a, quote, chronic autoimmune inflammatory dermatosis.
Which is quite a mouthful.
Right. It sounds so sterile. But looking at the clinical descriptions, that label feels almost too clinical for what the patient actually experiences. I mean, the pathology here is intense.
It is. The body's immune system fundamentally misunderstands its environment. It actively attacks its own healthy tissue, primarily in the anogenital area.
And the visual and physical presentation is, well, it's unmistakable, right?
Yeah, absolutely. It manifests as these ivory white patches of skin. And the tissue undergoes severe atrophy. It becomes incredibly thin and pathologically fragile.
Right, like tissue paper.
Exactly. And patients suffer from unrelenting pruritus, which is just severe itching. And because the skin lacks that structural integrity, any friction leads to incredibly painful micro tears.
Wow. And the sources really emphasize that the damage isn't just superficial, right? Over time, this chronic inflammation causes severe architectural changes to the vulva,
Yeah, the tissues can literally fuse together.
which is terrifying. Like, the clitoral hood can become completely buried in a condition they call phimosis, and the labia minora can sometimes resorb entirely.
Right. And biologically, this destruction is driven by deep immune dysregulation. The scoping reviews specifically highlight the overactivity of T helper type 1 cells.
Okay, T helper cells.
Yeah, and there's also the abnormal expression of a protein called ECM1, that's extracellular matrix protein 1.
And what does that scaffolding do normally?
Well, the extracellular matrix is the essential scaffolding that gives your skin its elasticity, its volume, and its resilience. So in LS, the immune system is actively dismantling that scaffolding at a cellular level.
Yeah, the stakes here for the patient are just life-altering. Because beyond the constant physical discomfort, LS drastically impact your quality of life. The architectural changes in fragile tissue often lead to severe dyspareunia, which basically renders sexual intercourse incredibly painful, or in some cases, physically impossible.
Yeah, the psychological distress there, the impact on relationships, the anxiety. It's a very heavy burden for anyone to carry.
It really is. And crucially, the clinical guidelines flag a 4 to 6% risk of this chronic, unmanaged inflammation transforming into squamous cell carcinoma.
Right. And a verifiable cancer risk elevates this from, just a condition requiring symptom management to one requiring aggressive disease control.
Which brings us to the established medical response.
Yeah.
Like, what do doctors actually do? When you get an LS diagnosis, the universal gold standard across all the guidelines is the application of ultra-potent topical corticosteroids.
Specifically, clobetasol propionate is the heavyweight champion here.
Right, clobetasol. So think of these steroids like a heavy-duty industrial fire extinguisher. When your immune system is setting your extracellular matrix on fire, you spray the heavy foam.
That's a great analogy, actually.
Thanks. I mean, they are highly effective at suppressing the immediate flames of the inflammatory flare-up. But here's my pushback. If steroids are the gold standard, why are we even looking for alternatives?
Well, because an extinguished fire still leaves you with a charred house.
Ah, right.
The steroids force the immune system to stand down, which stops further damage, sure, but they possess zero capacity to rebuild the scaffolding that the T helper cells already destroyed.
And that creates a massive clinical dilemma.
Yeah.
If the fire extinguisher is empty and the house is still charred, the medical community just sort of hits a wall.
Exactly. Patients with chronic LS have to use these ultra-potent steroids for years. But you can't continuously apply heavy-duty steroids to delicate tissue without severe biological consequences.
Like what? What happens long-term?
Well, long-term application predictably causes skin atrophy. You are taking tissue that is already pathologically thinned by the autoimmune disease, and you're applying medication whose primary side effect is further tissue thinning.
Oh, wow. So it's making the fragility worse in a way.
Yes. And on top of that, patients frequently develop tachyphylaxis.
Tachyphylaxis, meaning what exactly?
It's where the local cellular receptors downregulate, so the body simply builds a tolerance, and the medication just stops working entirely.
So the fire flares back up, but your extinguisher is totally useless now.
Exactly. That biological dead end is exactly what forced researchers to look past traditional immunosuppressants and start investigating the body's own regenerative capabilities.
Right. So we're looking at a fundamental pivot here, from just suppressing the immune response to actively trying to regenerate that scarred tissue.
And that pivot leads us directly to the application of platelet-rich plasma.
Okay, let's get into this. And I want to separate the science from the branding right off the bat because our sources are very careful about terminology.
Yes, the marketing can get very aggressive.
Yeah, I mean, the O-shot sounds like marketing jargon you'd see on a Los Angeles billboard. But it's actually a specific trademarked medical protocol developed by a Dr. Charles Runels.
Right. It dictates the exact injection sites, the local anesthesia used, the specific provider training, all of that.
But the actual biological engine inside the syringe, like the medicine doing the actual work, is just generic vaginal platelet-rich plasma, or PRP.
Exactly. And the foundational biology of PRP is what makes it so compelling to researchers. The whole process begins with a standard phlebotomy draw.
Meaning they just take your blood.
Right. Taking a small vial of your own blood from your arm, that whole blood is immediately placed into a centrifuge, which is a device that spins the vials at incredibly high speeds.
To separate the components, right?
Yes, based on their specific gravity.
I love this part because regenerative medicine often sounds like pure science fiction, but the first critical step is literally just the spin cycle on a biological washing machine.
That's a very accurate way to picture it, yeah.
Right. By forcing gravity to do the sorting based on weight, the heavy red blood cells drop straight to the bottom of the tube,
Leaving this really distinct golden layer of fluid at the top. That's the plasma, and it's now carrying a massive, hyper-concentrated dose of the patient's own platelets.
Okay, so we extract that golden layer into a syringe and inject it directly into the atrophied vulvar tissue. So going back to my earlier analogy, if the steroids were the fire extinguisher, these concentrated platelets are basically the heavy construction crew.
Exactly. I mean, platelets are famous for clotting blood when you get a paper cut, sure.
Right.
But when you concentrate them in plasma and inject them into damaged tissue, they act as cellular dispatchers. They carry over 800 different bioactive proteins and specific growth factors locked inside their alpha granules.
800. That's incredible. And the MDPI scoping reviews specifically highlight the role of one of them, VEGF, vascular endothelial growth factor.
Right. So once those platelets are injected into the hypothermic scarred tissue of an LS patient, they degranulate. They release these growth factors, which actively signal the dormant surrounding cells to wake up and start working.
Get to work, guys.
Exactly.
And the sources outline two massive biological reactions to this signaling. First is angiogenesis. The VEGF stimulates the creation of brand new capillary blood vessels,
Which physically reroutes fresh oxygen and nutrients back into those starved white patches of tissue.
right? And second, the growth factors trigger fibroblast proliferation.
Yes. Fibroblasts are the specific cells responsible for synthesizing new collagen and elastin.
Okay.
So by forcing fibroblast proliferation in that area, the PRP is quite literally instructing the body to manufacture new extracellular matrix scaffolding. It's attempting to reverse the structural fusion and atrophy that the corticosteroids simply cannot touch.
And the craziest part to me as someone who wants safe treatments is that because this therapy is entirely autologous, meaning it's drawn straight from your own arm just minutes before injection, there's virtually zero risk of an allergic reaction.
Right. For a patient suffering from a hyperreactive autoimmune disease, introducing a synthetic chemical or like a bovine-derived collagen could trigger a catastrophic flare-up.
Yeah, that would be a disaster.
Yeah.
But with PRP, your immune system recognizes the fluid as self. There's no foreign body rejection.
You are simply taking the healing payload your body inherently produces, mechanically bypassing the immune system's localized blockade, and delivering a concentrated dose directly to the geographic coordinates of the damage.
Okay, so in a biology textbook, that blueprint is flawless. It makes perfect sense. But the transition from theoretical biology to clinical reality is where this deep dive gets incredibly complex.
It always does.
Right. Does this highly concentrated construction crew actually rebuild the house when injected into a living patient suffering from severe LS?
Well, the clinical data we have right now is deeply divided. It really presents two completely different realities depending on which study you look at in our stack.
Okay, let's start with the observational data because the success stories documented in these specialized clinics are staggering.
They really are.
There is a key study by Benia Willison that focused on 28 women with biopsy-proven LS that was completely recalcitrant to steroids. Like, these were the patients who had hit that biological dead end we talked about.
Right. The hardest cases.
And after receiving PRP injections, 82.1% of those women completely stopped needing their topical steroids.
Over 80% walked away from the gold standard treatment.
Wow.
Furthermore, over half of that cohort reported a total 100% resolution of their symptoms, which includes the reversal of dyspareunia.
That's life-changing. And the evidence isn't just subjective patient surveys either. Our sources highlight a study by Tedesco that used video thermography to track the physiological changes.
Right, the thermography study, that's a great one.
Because LS tissue is heavily scarred and lacks blood flow, it registers as hypothermic or physically cold on a thermal camera. And Tedesco's imaging proved that after the PRP injections, those cold, atrophied areas visibly warmed up.
Yeah, the thermography physically verified the angiogenesis. The new blood vessels stimulated by the VEGF were actively perfusing the damaged tissue with warm, oxygenated blood.
Okay, but looking at the broader scoping reviews, I kind of refuse to accept those observational victories without heavy scrutiny.
As you should.
Because sitting right next to the Benia Willison data is a trial conducted by Dr. Andrew Goldstein. And this wasn't an observational clinic report. This was the ironclad gold standard of proof, a randomized, double-blind, placebo-controlled trial.
Yes. The Goldstein trial represents a massive hurdle for the adoption of PRP in mainstream dermatology.
Right. They took patients with LS, injected half with PRP, and injected the other half with a simple saline placebo. And the published result found absolutely zero statistically significant benefit of PRP over the salt water.
None at all.
No objective improvement in the architecture, no difference in the histology. So how do we reconcile an 82% success rate in one clinic with complete statistical failure in a rigorous double-blind trial?
Well, the scoping reviews dedicate a massive amount of analysis to this exact contradiction, and it all points to a systemic crisis in regenerative medicine generally, a total lack of standardization.
Ah, meaning what exactly?
Well, blood might be blood, but the physics of processing it are wildly inconsistent across the medical field. The reviews tear into the centrifuge protocols.
Because PRP is a biological product derived on site.
Yeah.
Right? It's not standardized like a factory-pressed pill of clobetasol.
Exactly. Every clinic and every trial uses different centrifuge machines spinning at entirely different G-forces, and the physics of the skin are critical. Platelets are incredibly fragile cellular structures.
So they can break easily.
Yes. If a centrifuge spins at a G-force that is too high, the shear stress causes the platelets to rupture prematurely in the tube. They release their growth factors into the plastic vial before they ever reach the patient's tissue.
Oh, wow. So you end up injecting dead cellular debris.
Precisely. Conversely, if the spin is too slow or too short, you don't adequately separate the plasma from the red blood cells, resulting in a tiny microscopic concentration factor.
So the construction crew in one study might be 50,000 heavily equipped workers, while the crew in the Goldstein trial might have been a tiny fraction of that size because of the specific commercial kit they utilized.
Exactly. And the MDPI reviews also heavily scrutinize the injection protocols. There's just no universally agreed upon standard for how deep the needle should go or what volume of plasma should be injected per square centimeter of damaged tissue.
That seems like a huge oversight in the field.
It is. Furthermore, the selection of the patients themselves varies wildly. A therapy that works wonders on early-stage inflammatory LS might be entirely useless on end-stage, severely fused tissue where the fibroblast population is already fully depleted.
Right, you can't wake up workers if they've already left the site.
Exactly.
So the scoping reviews essentially conclude that until the medical community standardizes the exact G-force, the specific platelet concentration factor, and the depth of delivery, the data will remain hopelessly contradictory.
Unfortunately, yes. The subjective quality of life improvements reported by patients in observational clinics are massive and consistent. But the objective, high-level scientific evidence is currently far too weak and fractured to legally replace corticosteroids as a first-line treatment.
So it remains strictly a second-line or adjunctive therapy, a biological option for patients who have completely exhausted the traditional pharmaceutical route.
Exactly.
Okay, but that mixed clinical reality brings up a vital, practical question for you, the listener, navigating this space. If the rigorous double-blind trials are failing, how are specialized clinics legally offering this treatment? And is it actually safe?
The regulatory landscape requires really careful navigation because the terminology used in clinic marketing is often designed to obscure the truth.
Yeah, you frequently see badges on websites claiming the O-shot or PRP is, quote, FDA approved.
Right. And the sources are crystal clear on this regulatory loophole. There is absolutely no such thing as an FDA-approved ERG shot for the treatment of Lichen sclerosus.
None. Zero.
The confusion stems from the FDA's 510(k) clearance pathway. You see, the FDA's mandate is to regulate medical devices and pharmaceuticals, not the individual practice of medicine by a licensed physician.
Okay.
Therefore, the FDA reviews and clears the Class II medical devices, so the specific centrifuges and the sterile collection tubes used to process the blood.
They certify that the mechanical centrifuge safely separates the blood without introducing bacterial contamination.
Precisely. But the subsequent act of drawing that plasma into a syringe and injecting it into the vulva to treat an autoimmune skin condition, that is classified as an off-label clinical application.
Which, to be fair, off-label prescribing is incredibly common across all branches of medicine. Doctors use their clinical judgment to utilize safe therapies for unlisted conditions all the time.
Oh, constantly.
But it fundamentally means the governing regulatory body has not vetted or endorsed PRP specifically for LS.
Right. But despite that lack of official endorsement, the safety profile of autologous PRP remains one of its most compelling attributes. Large-scale reviews of the literature show a near-total absence of serious adverse events.
Which is huge, especially when you contrast it with other alternative treatments desperate patients turn to. Like the sources note that energy-based therapies like fractional CO2 lasers or radiofrequency treatments, those carry specific FDA warnings.
Yes. Blasting fragile, atrophied LS tissue with thermal energy has caused severe burns, catastrophic scarring, and actually worsened the architectural fusion in some patients.
That's horrifying.
Yeah.
But PRP is a room-temperature autologous biological fluid. It does not burn tissue. The documented side effects are almost exclusively limited to, like, transient, localized swelling or minor bruising caused by the physical trauma of the needle itself.
Exactly. But, and this is important, our sources explicitly outline strict contraindications. This is not a universal treatment for everyone.
Right. You cannot undergo PRP therapy if you are pregnant or breastfeeding, primarily because the massive systemic hormonal shifts drastically alter the body's baseline regenerative response.
And it is strictly prohibited if a patient has an active pelvic infection. Furthermore, if a patient suffers from blood clotting disorders or severe anemia, their baseline platelet count and viability are compromised, which essentially renders the PRP ineffective.
That makes sense. And the timing of the injection is also heavily regulated in the protocols, isn't it? Like you cannot inject PRP straight into the middle of an acute, fiery LS flare-up.
Right. The local tissue environment is just too chaotic and inflamed at that point.
So the guidelines dictate that a patient must stabilize the acute flare-up using the heavy-duty fire extinguisher, topical steroids we talked about, and only then deploy the PRP construction crew to repair the residual architectural damage.
Yes. Timing the regenerative phase to follow the suppressive phase is absolutely critical for clinical success.
Okay. But beyond the biological timing, we have to look at the absolute financial reality for the listener. Because this therapy lacks the backing of massive, standardized, randomized controlled trials, it is legally classified as investigational.
Which unfortunately means the entire financial burden falls squarely on the patient.
Yeah. It is not available on the NHS in the UK, and it is almost universally denied coverage by private health insurance providers in the United States.
It's a huge barrier.
It is. Looking at the real-world clinic data in our stack, patients are often looking at an out-of-pocket cost of around £1,500, or roughly $2,000, just for the initial protocol.
And because this relies on the body's cellular turnover, many patients require multiple successive sessions or even annual booster shots to maintain the restored tissue health and keep those blood vessels perfused.
So it's a profound financial commitment for a biological therapy that is, frankly, still actively evolving in the scientific literature.
It really is.
So just synthesizing this massive stack of sources for our deep dive today. If you are navigating the devastating reality of vulvar lichen sclerosus, vaginal PRP and the O-shot protocol represent a biologically intuitive, highly promising second-line therapy.
Absolutely.
It leverages your body's own autologous growth factors, your personal cellular construction crew, to try and force angiogenesis and regenerate scarred extracellular matrix where the heavy-duty suppression of topical steroids fails.
Right. It provides a mechanism for actual structural repair, coupled with an incredibly safe biocompatible profile when you compare it to surgical interventions or thermal lasers.
But the clinical reality is heavily nuanced. The extreme lack of standardization regarding centrifuge physics, spin speeds, and platelet concentration factors means the industry is currently fractured.
Yeah, your clinical outcome may vary wildly depending on the specific equipment your specialist uses and honestly your body's baseline cellular health.
Exactly. It is not a guaranteed miracle cure, but rather a powerful investigational tool that requires a highly skeptical, thoroughly researched consultation.
And as we close out this analysis of regenerative medicine, the mechanics of PRP actually leave us with a really fascinating forward-looking implication to consider.
What's that?
Well, we spend so much time debating the physics of the centrifuge and the speed of the spin, right? But if the entire premise of autologous therapy relies on the patient's own blood serving as the ultimate construction crew to repair chronic disease.
Wait, I see where you're going. The quality of the crew dictates the quality of the repair.
Exactly. And it leaves you with a really profound question to chew on. If our biological baseline, our own centrifuged plasma, can potentially outperform synthesized pharmaceuticals for severe tissue damage, what happens when we shift our focus to optimizing the source itself?
That's a great point.
Right. Could the future of treating complex, chronic autoimmune conditions rely less on standardizing the mechanical centrifuge and more on aggressively optimizing your own epigenetic factors? I mean, your diet, your stress hormones, your systemic inflammation, just to ensure your veins are pumping the highest possible quality of regenerative medicine before the blood is ever even drawn.
Now, that is a truly wild thought to end on. Something for you all to think about until next time.